Next, I call up Mphele Tladi, who's going to chat to us about whether we should be repairing ligaments in the multi-ligament setting. Is it better than reconstruction? So if you can't reconstruct them, should you be repairing them? Mphele.
All right, thanks, Brad. I'm not getting any movement here. All right. Oh, sure. All right, that's a bit too far. All right, thank you, Brad. So I've been tasked to present ligament repair in the multi-ligament setting. It's really ligament repair better than reconstruction. I thought it's quite relevant actually to first just start with the history of knee surgery. And I think of relevance to us is the middle section there, which talks about the soft tissue operations in knee surgery. So although the ACL was initially discovered and well described by ancient Egyptians, and also anterior instability was described by the Greek and Roman physicians. But the first surgical repair was done in 1895, towards the end of the 19th century, by Sir Arthur Robson. And then following those developments, grooves did a reconstruction some 10 years or so later. And of note is that historically, it has been known that, that was a common belief that loss of motion, chronic instability, and poor functional results were actually common. And this was well documented in quite a number of papers which were published then. But in the 21st century, with the evolution and more understanding of the anatomy and biomechanics, and the development of innovative techniques and improvement in post-operative protocols, one can safely say that we have come a long way, and actually we are starting to have better results compared to then. Just as an intro, just to define these multi-ligament injuries, this basically means at least two of the four major ligaments in the knee, your ACL, your PCL, your collaterals, including your corners there. So it's quite uncommon, as Brett has mentioned, in one review study by Levi et al., they reported 0.2% of injuries which had multi-ligament injury. And the problem with that is that with that very scarce, uncommon as it is, it has also resulted with the paucity of high-quality literature to better explain this and also explain on the management of these injuries. So the management, again, is complicated by associated injuries, as it was explained by the previous speaker. I won't bore you with the classification. That's the Schenck classification. Of note is that it has been used in many papers as a guide for the treatment algorithms and also to prognosticate, with the high classes tending to have unfavorable prognosis compared to the low classes there. And then again on the classification, the common patterns which are described in the literature. From that paper there, from Kering et al., it was a literature review. It showed that the common patterns which are commonly seen in order of appearance there, the ACL and the MCL. The second one was the bicruciate with the lateral collateral and posterolateral corner. And the third one was where all ligaments were involved. 40 years down the line, with the improvement in principles of treatment, still again, there is no optimal treatment which has been described in the literature, so it's still a controversial issue. And then again, in 2010, the journal there of operative techniques in sport medicine invited clinical commentary on management of these injuries. If you go to that paper there, you'll see there's quite a number of articles there. And if you look at the articles, most of them will be saying how I manage, how we manage, and our experience. So really there was no consensus which was reached at the end of the day. So it just goes to show the controversy which is there with this treatment. But in 2016, I can safely say that we do have a consensus that with non-operative treatment, we tend to have poor results in the short and long term. As you can see on the table there, from Levy et al., it was a meta-analysis which was done there. And then they show that, if you can see at the bottom there, that with surgical treatment, we tend to have better results. with return to work, return to sport. And if you look at loss of motion, there really is not something quite significant there. All right, and then with the ligament repair, in addition to time as a deciding factor, other factors which are associated or which repair depends on is the severity of the disruption, location, the principal pathological condition, age, the activity need, and the surgical experience. But with the surgical experience, I would rather say with the team experience rather than surgical experience. Again, the aim of ligament repair, we try to restore the anatomical integrity of the joint, and this should be done under proper tension. And then augmentation should also be considered in these cases. Anything from your triangular configuration screw in a reverse mattress for your collaterals or your internal splinting in your ACLs and your PCLs. And generally, the repair was known to be a viable option for non-cruciate ligament injuries. And this was also advocated that this has to be done early for you to get preferable results. So early movement was quite important in these ligament repairs for you to get good outcome. Just to take you again, the foot guys have published papers which actually show that with early range of motion in the Achilles tendon rupture, they tend to get good results, because how they explain is that with the early movement, you get the fibers which are healing in line with the forces which are applied to that. So as a result, the reason we're having the same re-rupture rate with your patients who were treated conservatively and patients who were treated surgically but then put in dorsiflexion post-op, the re-rupture rate was the same. But with patients who are allowed to mobilize early, and then the re-rupture rates tend to be better. And then again, if you have the best possible repair that one can have is to, if you have anatomy which is restored and the tension is also done correctly. So theoretically, early motion should be feasible, because it means that you've basically restored the anatomy, the ligaments are isometric. So you should really have motion which is unstressed and early motion in these cases. Now, starting with the topic at hand, repair versus reconstruction, is quite a controversial issue. So what I'll do is just to go through it in terms of the ligaments involved, your cruciates, and then we'll talk about the collaterals. I think the mid-substance and avulsion, I'll just talk about the mid-substance. I think the avulsions were well covered from the previous speaker. And of note again is to talk about the single stage, which is something which is emerging quite often nowadays. But the challenge which one had with the literature which I've reviewed, trying to compare the two, is that apart from less literature being published, one doesn't find one outcome measure which is universal to all studies there. So comparing is quite a bit difficult, and also most of the studies have a small sample size. With the posterolateral corner, two studies which were high-quality studies which I thought would be relevant was the one which was done in 2005 by Stannard et al. So they looked at the posterolateral corner and looked at their results, and they found that the failure rate was high with the repair at 37 compared to 9% in patients who had done reconstruction. And that was in 2005. There was still a similar return to work compared to reconstruction. 2010, 5 years later, again, the rate of failure is still high there compared to the patients who had done reconstruction. But again, the ascent reconstruction is more reliable compared to your repair. And Laprade, who's the father of the posterolateral corner, who does more of this, also advocates the same thing. So with posterolateral corner, it's better to do a reconstruction than a repair. With your medial collateral ligament, study which I found, this was a systemic review. They found that the satisfaction rate for both groups was the same. So this was done in 2000 for patients who had medial collateral ligament injuries. Now with the cruciates, the first study which was done, which was more relevant, was the one which was in 1999. And then Mariani found that combined ACL and PCL, the functional outcomes, there was no difference. But the return to pre-injury level, there was a low rate there. But in 2013, some years later, a meta-analysis was done. We showed that if you don't treat the ACL and the PCL, you tend to get poor results. And if you treat it, that's where you get good results. And then they basically showed that there's no difference between suturing and reconstruction in the cruciates. Now, I came across this study, which is a recent study, which was published in 2015, the anterior cruciate ligament repair, which they say has been revisited. So they were looking at internal bracing. And then they showed that there was greatest improvement, which was seen in these patients in terms of sporting activities. Now, how this was relevant to me is that there's a renewed interest in ACL repair. So guys are starting to more and more, again, think about repairing these patients. Now, single-stage repair. Historically, it has been known to have poor outcome in terms of motion. And then the philosophy of the proponents of this single-stage approach is that they would rather be address everything in one sitting, because addressing only a portion of it will lead to residual laxity. And then they also like the fact that you have one anesthesia, one rehabilitation, and there's also reduced cost in that. So they would rather be treating stiffness than treating recurrent instability, which they believe is quite difficult to do. Repair versus reconstruction, again, in the single stage. I found these 3 studies here. And the common outcome factor which they were using was the range of motion and also the LEOM score, which is looking at it's a subjective score which looks at the function of the sample after the repair. What they found in most cases is that the first one is 89, 83, and 87, and then these figures are comparable to those patients who were treated with reconstruction. And the flexion and extension loss, the motion loss was more or less comparable again in this case. So with that being said, these guys are getting good results which are comparable to reconstruction. And then they advocate that single stage repair is actually the way to go. In conclusion, I would say we are actually going back into the future. From an era of where we did a repair in 1895, the first ACL repair, to an era where there was reconstruction. Now everyone is starting to think of repair as a viable option for this patient to restore the anatomy. And in conclusion, I would say based on the good reports which our guys are getting from the single stage repair and the comparable results which we are getting with most ligaments from repair, except for the posterolateral corner, which I believe is work in progress. And again, all advances that we are getting in these techniques and post-operative care, I think really if I were to answer the question if ligament repair is better, I would say it might be controversial now, but certainly in the future it looks like it's going to be a better option. Thank you.
Thank you, Mphele, for a thought-provoking talk. Please save your questions for later. I'm sure there are plenty of those.